So what I get to do is have a conversation with our Kimball lecturer, whose credentials are up on the screen. And what we thought we'd do before we start talking is show, again, a very brief video clip with some highlights from his talk. And then he and I will talk for a while. And if you all have questions that you want to put into the chat that you want Professor Williams to address, please go right ahead and do that. But let's start with just a quick compendium of his talk. Thanks, team.
COVID-19 and communities of color, and I will focus on understanding social inequities as well as the opportunities for building community immunity for future pandemics. So we've gotten a big sense of some of the challenges producing these inequities. I want to shift to talk about what can we do about it. How do we build community immunity? We need to think of how we can create communities of opportunity that will minimize, neutralize, and dismantle the systems of racism that create inequities in health. We need to build trust to improve patient-provider relationships and the quality of medical care. Medical mistrust is a problem. It's driven for many by misinformation. It's driven for others by historical or ongoing injustice. Mistrust is typically viewed as a characteristic of an individual or community. I am strongly suggesting that we rethink about mistrust as a phenomenon created, sustained, reinforced by a system that is generating social inequality. Medical mistrust matters profoundly. It leads to lower utilization of care, lower adherence to medical advice, poorer management of health conditions, lower likelihood of good long-term relationships with health providers. It, in fact, contributes to racial disparities in care. Medical mistrust is not merely the opposite of trust or the absence of trust. It is not just about interpersonal trust, but also about trust in institutions and systems. And medical mistrust is a protective response on the part of disadvantaged communities against interlocking systemic inequities in education, in jobs, in housing, in healthcare, dealing with daily discrimination, stigma, and so on. Let me conclude by talking about what is holding us back. And I would argue there are three communication challenges. Most Americans are unaware that racial inequities in health exist. Maybe in the post-COVID-19, there's greater awareness. But we also need to build a science base to develop the political will, and we need to build empathy. W.E.B. Du Bois, a giant intellectual, African-American intellectual of the late 19th, early 20th century, wrote a book in 1899 about the Philadelphia Negro, has a chapter on Negro health. And he laid out the disparities in health that existed in 1899 in Philadelphia. And he came to the end of the chapter. He said the most difficult problem with racial disparities in health is the peculiar attitude of the nation. He continued, there have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. In fact, as this recent review shows, there's a racial in-group bias found across the world. These are studies of brain imagery, seeing persons of your own race or of a different race suffer. Do you empathize with them? And if they're of a different race, you're less likely to. What's the policy implications of this racial bias, this empathy, lack of empathy? When we lack empathy for a group, we do not support policies to address the needs of that group. So we need to find ways to build empathy, but we also need a commitment to equity. Equality gives everyone the same thing. Equity provides what everyone needs in order that they can thrive. Equality is a good idea if we all start at the same place, but when we are unequal, then equality is not the optimal idea. There are many edifices that have produced the racial disparities in health that we deal with, we have dealt with for hundreds of years, and we still deal with today. We need to make a new commitment to restructure those edifices.
Wow. David, thank you so much for a really, really powerful talk. And one of the ways to know already the impact of the talk is the number of times other people speaking in the meeting, on the chat, in the small groups, have referenced your talk. and have connected to it in various ways. I want to start by inviting you to share a little something about yourself, how you decided to focus on this area, either what it was in your personal background or your own life trajectory that made you decide this was the area you were going to focus on, or more recent experiences from COVID that will help the group understand about who you are.
I would say I'm a child of the 1960s. And so I have been very concerned throughout my life, my academic studies. My earliest work was in the study of religion, then in public health, then in the social sciences. I've always been interested in issues of inequities and social justice. My own lived experiences as a Black male in the United States certainly reinforced the inequities. I'll just give you one example. I could entertain you for hours with examples, but just one quick one. After completing my doctorate at the University of Michigan, I started my career working as a faculty at Yale, joined appointment in sociology and in public health. And my main office was in sociology. I would walk to the School of Public Health, where I taught 2 classes each year, joined with a physician. And I spoke to my colleague who had done what I did, an older white gentleman, and he says, you don't need the School of Public Health door was always locked. And you could ring a buzzer to get in, or you could get a key. He says, you don't need a key. I never have had a key. He'd been there at Yale for 40 years. He says, you don't need a key. Just press the buzzer and say your name, say you're Professor Williams. They'll open the door for you. And I went my first day going to class. I pressed the buzzer. He said, who is it? Someone in a room somewhere that's looking at me in a camera. I said, I'm Professor Williams. What is your full name? What department are you in? Why are you going to the building to teach my class? What is the title of your class? What room is your class in? What is your mother's maiden name? He really didn't ask what's my mother's maiden name, but it was a series of questions like that. And I said, okay, it's the first day. Okay, let's give him a break, first day. So I did nothing, went to class, very upset. But the next week, I went back a week later, teaching the class. It was a class that met once a week, and I ran through the same set of questions again. So I walked down the hall and got a key so I wouldn't have to deal with it. But that's a little incident. I have big ones, encounters with the police that we don't have to get into. But your own lived experiences brought home the degree of inequities that existed, and certainly motivated me. My dissertation work was on a predominantly white population, looking at income and education and how it predicted outcomes. But I was certainly interested in what happened with race and ethnicity, and I have certainly devoted much of my career to studying factors outside the healthcare system that shape health in profound ways.
Everybody else's
yes.
experience.
You're muted.
Boy, I hope not. People presume that their experience is everybody else's experience, and it's really not. White people may presume that Black people have the same experience that they have. And so one of the things that I thought was powerful about your slide on structural racism was the way in which it might signal to white people that their experience their intentions may not reflect the experience other people have. You've taught at Michigan, you taught at Harvard. You're teaching at Harvard. What's the reaction you get to that slide? How do your students learn about structural racism?
Yeah, I teach an undergraduate course called Poverty, Race, and Health. I developed it as a faculty at Yale, taught it at Michigan, teach it at Harvard. I teach, it's an undergraduate course. I teach some of America's brightest students coming out of our system. And really, our educational system in this country is failing in terms of really preparing our students because if these students that I have taught, America's best and brightest, are totally unaware of racial inequities and are clueless about the degrees and always tell me at the end of the semester how much they learned from my class. They had absolutely no idea that these things were happening in the United States. And public opinion research shows that most Americans think that America had, past tense, a racial problem. But Martin Luther King, the civil rights movements, the problems have been solved. And that there is no structural racism. There is individual prejudice, and that minorities are as likely as whites to be prejudiced, but there's no embedded, deeply structural things. All of those problems were solved in the 60s, and that's where most Americans are. I will also tell you, there's recent research suggests that most Americans underestimate the degree of racial inequity that exists, inequity in wealth, in income, in education, and that the degree of underestimation is greatest among highly educated whites who believe in a just world. Wow. That's where you find the perception of minimizing the inequities being the greatest.
Wow. So you described many of the factors that have led to the current status quo. You talk about inequities of wealth, income, segregated housing, and you make them visible in a way that certainly has high impact. At this forum, the 180 people listening to us right now, they are largely leading in healthcare. They may not be able to reduce childhood poverty. They may not be able to enhance income and employment opportunities. Can you offer thoughts targeted to healthcare leaders about steps they could take, what their biggest opportunity is? Todd Staub said in the commentary, lead from where you stand. Can you talk about that?
I'm really glad you asked that question, because there's so much we can do. One of my heroes is Jack Geiger, a physician, and he started the first community health center in the United States in Boston, and then developed one in Mississippi. And at his clinic in Mississippi, he would write prescriptions for malnourished children for food. Prescriptions for food that were filled by the local grocery stores and paid out of the health center's pharmacy budget. It's just an illustration of the innovation and creativity and leadership that an individual physician could have. I think of Barry Zuckerman, chair of pediatrics at the Boston Medical Center, who started the Medical Legal Partnership, so that primary care providers in pediatrics can refer to a number of specialists, and one of those specialists is an attorney. An attorney, you see, all the asthma medication in the world will not enable a child to breathe symptom-free if that child goes back to live in the same housing conditions that brought on the problems in the first place. And then a lawyer who talks about violation of the laws of the state of Massachusetts can make progress where a parent did not. Thinking of the Boston Medical Center, they have a rooftop farm that is growing high quality produce to distribute to patients and their families, employees, and visitors. So what I'm saying is there is a range of things that healthcare systems can do. There's a wonderful paper by one of my colleagues, Howard Koh. It was published earlier this year. It is on anchor institutions and gives the best practices of anchor institutions. And anchor institutions is a term that is increasingly used to refer to healthcare systems. As you may all well be aware, that the healthcare system in the United States is the country's largest employer. We are the cornerstone of healthcare systems, the cornerstones, economic cornerstones of many communities. And the Healthcare Anchor Network is a resource that lists wonderful examples of how healthcare systems, so we can advocate within our healthcare systems of making a difference. And there's so many examples across the country of healthcare systems that are doing really innovative things. Let me just mention two in the interest of time. One is Dignity Health, that has invested $90 million in low interest loans to help to increase affordable housing in the communities in which they have healthcare facilities. I visited Loma Linda University Medical Center's Gateway College. This is an academic medical center sitting right next to San Bernardino, one of the most disadvantaged communities in the United States, a community in which less than 20% of high school graduates go on to any higher education. And so this academic medical center has used its community benefit dollars, developed a Gateway College that is to reduce unemployment and to provide job skills for high school graduates. It offers certificate programs like a certified nurse's assistant, a pharmacy tech, a surgical tech, a community health worker training that's given these young people jobs. And I met with some of those young people, and what was most striking, it wasn't that they were succeeding in these programs, but that opportunity had changed their vision. They were thinking of going into nursing and going into medicine just from this opportunity that had showed them there was more possible in their own lives. So the range of things that healthcare systems can do, and those of us who work within those systems can be advocates. I just encourage you to go to the website of Healthcare Anchor Network as one resource, and Howard Koh's paper in American Journal of Public Health as one resource that lays out a range of opportunities.
That's terrific. And let me reassure people that we are making a recording of the forum. We are capturing the chat, which is whizzing by. So people will have access to that kind of information. You know, you describe medical mistrust as created by a system that generates inequality. In that sense, I guess some of the strategies that you're describing for healthcare institutions really are core strategies for earning back trust, that if the institution can be visibly seen and publicly committed to addressing a system that generates inequality, trying directly to address that inequality, probably we're underrating that as, I'll call it a quality improvement strategy, a strategy for increasing health status in the community, and probably institutions that do that are going to be more successful at having an impact in community health. You talk about things that are holding us back, and one is awareness, and you talked about that earlier, and your talk goes a long way toward raising awareness. And as I think I've already mentioned, many attendees at the forum have said, can we share this talk with family members, with students, with colleagues? The answer is absolutely. We wanted it to be given first here. But the third thing you talk about is empathy. And one of the questions Jay Bott put into chat was, are there strategies for scaling empathy? That empathy is a root cause. You talked about lack of empathy. You talked about even potentially neurobiologic basis of empathy. Are there strategies for closing the empathy gap that may be scalable?
That's a really great question. I think the science in what we can do to increase empathy is still growing. There is some evidence that persons who had a lot of meaningful interracial interaction in their early socialization have higher levels of empathy for persons of outgroups. There is evidence that individuation, which is a useful strategy to reduce implicit bias, also increases empathy. And individuation is the opposite of what we as human beings normally do, is social categorization. We put things into categories. That's how we simplify the complex cognitive information we deal with every day. And individuation means we take extra time to attend to the unique characteristics of this individual. We try to understand each person as an individual and not based on their race, their age, their gender, as what is the natural thing that we do. So we know that individuation helps. There's also some evidence that when we see ourselves together on the same team, that can build empathy with the other team members. But there is much that we need to learn. There was a randomized control trial published in the journal Science that was focused on building empathy for transgender individuals, and had canvassers go out to meet with just regular voters. And the key to building empathy was to help that voter put themselves in the shoes of a transgender individual, and by thinking of a time in their life where they had been treated unfairly and how they felt, and so that they could experience and sympathize and empathize with the challenges of others. That intervention was remarkably successful. It increased empathy. It increased the levels of individuals voting for this initiative, this ballot initiative, and it worked whether the target persons were Democrat or Republican. It worked whether the canvasser was transgender or not. So it shows there's promise. The sobering thought is there's a commentary published with that paper that said the researchers tested 10,000 conversations, 10,000, before they came up with the right one, just with the right words that worked to create this empathy. So it does suggest that it isn't easy, it's not straightforward, and it takes a lot of time, effort, energy, and that's why I call for the research that would really guide us and would help us to better identify how we can tell the story of the challenges of disadvantaged populations in ways that can emotionally connect, and we can feel the pain. I would argue, no, without any empirical evidence, I would argue that the power of the George Floyd death and the video, and thank God for that person who taped the video, but the power of it and what made it a worldwide phenomenon was it was so vivid and so outrageous that people had empathy for a man handcuffed on the ground, still having someone having his foot on his neck for so long, despite his pleas for mercy and for survival. And I think that video produced empathy, and it told the story in a way that maybe a newspaper article would never have. But people could see it, and it was so vivid, and you could place yourselves in his shoes and just imagine the impact. So I think that's a huge area of research, but we need to identify it as a priority and see how central it is for us to develop the political will and the political support to make the changes that are necessary.
Well, that is such a helpful framing and opens up so many possibilities for medical education, medical training, and institutional training. As I said earlier, the challenge of developing empathy among healthcare providers and everybody on the healthcare team, it's not new. The patients come in, and whether it's the X-ray tech or the highly specialized physician, they're living in their world, and they're not necessarily reaching across to the world that the patient has. I know that many of our colleagues in medical education have looked at humanities as a way to try to develop empathy, reading literature, reading stories, seeing movies. I guess I hadn't thought before ways that connects to a racial justice agenda, because if your point is right that and that W.E.B. Du Bois quote just blows me away, that people regard suffering with indifference. If the secret is to try to figure out how to understand suffering better than we do, that's clearly got to be at the root of how we move forward. Any further reflections you want to offer on that? We're almost out of time.
My only other reflection is how serious a problem it is and how early we need to start. I showed the example of one study that shows that at the age 5, white children in America do not have an empathy gap. By age 7, there is evidence that it is emerging, and by age 10, it is pronounced. So it suggests it's a huge challenge we face. It's a problem we need to address early in the socialization of all of us. We need to do all we can to use at least the knowledge that we currently have to make a difference and to see every child of humanity with the dignity, the respect that they deserve.
Thank you for articulating that so clearly, and I think your concluding observation that people say the system is broken. It's not broken. It's achieving precisely the results it's designed to achieve. A lot of people are going to have to want it to achieve a different set of results than what it's achieving. And how we can work at empathy at scale, and Ofo Mbaka has has asked, how can we get to empathy without Black and brown suffering? Is there a way to make people experience empathy without that? Thoughts on that?
I wish I had a magic bullet. I do think that this conversation we are having is so important. I honestly think from my own 3 decades of teaching that there are persons who lack empathy, but who totally lack awareness. And we shouldn't assume that everyone knows and understands all of the things that persons of color experience in this country. My experience is a lot of people who mean well, truly have no understanding, and we need to think of how we create the opportunities that within medical education, within medical training, people are informed, people become aware, and we build that knowledge base and build those skills that it will take for us to be successful in the care of individuals.
Well, I'll close sharing a suggestion Don Berwick made, that what if everybody took community benefit dollars, which are part of every healthcare institution's budget, and for 2 years focused on homelessness, hunger, or the opioid epidemic? The idea of a national coordinated response on the part of healthcare, focusing on things designed to address structural racism, that's a really powerful idea.